Good afternoon, everyone. Thank you, organizers. So, of course, the last topic will be from GU. This is gastrointestinal, because the outcome, the chronology is very well set, because this biliary tract has a very poor distal outcome, even if the best to best lines will have. So, not taking much of time. So just giving a brief, sometimes we just get confused what is intra, what is extrahepatic cholangiocarcinoma, and we sometimes don't even get to know what exactly the baseline or the root cause where it started. So we just start in the forms of biliary tract, so we label as a gross it's a biliary tract cancer, and sometimes even the primaries in the gallbladders, and we sometimes don't able to get the biopsies. So basically the incidence and the epidemiology of this biliary tract cancer are fluid and they are complex. And if you see, approximately 3% of all the GI malignancy, it is constituted by BTC. And this ISCC is just increasing, and this extrahepatic is decreasing internationally. So the etiology, not going to detail, and these are more common thing in our setup. Of course, the metabolic diabetes, mellitus, and obesity is one of the most important things to be taken care of. And again, in the gallbladder, cholelithiasis per se does not cause this, but it has seen that there is some of the association seen in this. And the parasitic infection, not common in our country, maybe in the China or Thailand, where this liver fluke or clonosis infection is some prevalent, they have these things. So the most important, again, the treatment approach, always the standard approach, if it is operable, we have to go for surgery and then the adjunct therapy accordingly. And if the patient is an inoperable candidate, we have to select for the systemic therapy. And variable approaches are there for different centers, like they are using any of the loco-regional therapies or the radiotherapy or some of the other photodynamic therapies. So first line, the standard of care, everybody is aware of this GEMSIS. This is the ABC02 trial. This is a standard line, and a decade back it came and it has shown a very good result. And in this, the overall survival was 11.7 months versus 8.1 months in the single arm gemcitabine with a hazard ratio of 0.64. The next is the GEM-CIS combination along with the nab-paclitaxel for the advanced. It was a phase 2 trial, and it has shown the again some response, but it was not into the practice of the combination of 3 drugs. So after this first line for the GEM-CIS or for the other gemcitabine based therapy, we were not having any other drugs, and basically the prognosis or the outcome of the patients after the first line therapy is very dismal. We sometimes use the FOLFOX, all other therapies on the same. This was a trial which showed that the one of the drugs, that is durvalumab, which can be used with a combination of the GEM-CIS in the first line, and it was a phase 3 study. And the locally advanced or metastatic BTC were taken, and the patient were randomized into GEM-CIS combination, or along with the GEM-CIS, it's a durvalumab. So the primary objective of this trial was overall survival, with the secondary objectives were PFS and objective response rate and duration of the therapy. So demographic and baseline characteristics were well matched in both sides. The primary endpoint, if you see with the GEM-CIS and the durvalumab combination, is 12.8 months as compared to 11.5 months. It's a marginal difference, but the hazard ratio was 0.8. So it means little bit hard to justify at a very high cost how to add this durvalumab. And I have not seen any patient in my practice also which I even convinced for this durvalumab. So secondary endpoints, tumor response was again better on the patient who are receiving the durvalumab. That is 26.7% as compared to 18.7% in the GEM-CIS combination. So if you go with the subgroup analysis, if you see all the table in the hazard ratio is close to 0.8 or 0.9. So it favors that durvalumab combination in along with the combination of the GEM-CIS can be one of the therapies run day to day, means nowadays. But only it has to be challenged with a financial toxicity to the patient. So what after then we have a progression following GEM-CIS or GEM-CIS durvalumab combination, single-line therapy and beyond, and we don't have much of the therapies here. And we usually go for some of the NGS-based panels or some of the PD-L1 testing or MSI testing or TMB, which is a part of all the gastrointestinal tumors. We are taking out TMB and MSI. So these BTC, these all share a genomic alteration in the cell cycle regulations like CDK, N2B, and ARID1A mutations. And intrahepatic cholangiocarcinoma, they have FGFR mutations or IDH1 mutations or BRAF substitution with the MET amplification or with the KLORAS mutational frequency. And other pathways like PIK3, mTOR inhibitors, they were also commonly seen in the extrahepatic and the gallbladder tumors. So these are just graphs showing of all intrahepatic or extrahepatic or the gallbladder cancer, which all the tumors which we can see, and mostly if you see FGF are seen in the close to 10% patients, all these patients. So this was a trial in which this IDH1 mutation, it is showed that vascudanim in the patient with advanced cholangiocarcinoma, they have shown some survival benefit in the second line. And this patient, the median overall survival was 10.3 months as compared to 7.5 months in the placebo arm. So next was this pemigatinib. That was also again a phase 2 study, and it has shown that patients who had FGFR2 infusions or rearrangements, they have shown some response rate close to 36%, and the median duration of response was 9.1 months. And the responses was lasting for more than 6 months in approximately more than 60% patient, and close to 18% patient in more than 12 months. So next again, this BRAF inhibitors along with the MEK inhibitors, this gene has been found in approximately 5% of the patient, the BTC, and it has achieved a 51% response in patients with who are having this mutated cholangiocarcinoma. So this is a figure showing all these second line biomarker and the various trials and the various PFS OS survival benefit with these drugs. So if you go, this FGFR and IDH1 has shown some benefit as compared to the HER2 based. So the thing is this pemigatinib, again, it's not available with us. We have to get it from the outside, and the cost again is one of the issues when we are giving this to the patient. So this is a graph showing, table showing the other mutations can be endatinib or pembrolizumab or entrectinib. So these are all the second line therapies which we might confer to the patient, and they can have some outcome as compared to the placebo. So if we have done the this NGS panel, we don't have mutation, then what next? Again, we are again to this level, then we are concerned, how about immunotherapy? And always we are talking the IOs in all of these gastrointestinal cancers, like initially about the gastric, and again this pancreatic Vamsi I just told. So a lot of drugs are there, but again there is no as such biomarker which can decide whether it's MSI high or TMB high, or we can use any CPS scoring. There is no such as compared to the BTC. So we have used the patient who have a high MSI or TMB in those patients. So this was one early studies, and this was basically the efficacy and safety of the pembrolizumab in the treatment of the advanced biliary cancer. The patient who have already received 2 or more than 2 lines. So in this, it has been seen that there is some sort of response to the patient who have the PD-L1 positive as compared to the PD-L1 negative. So if you see with this, these were both basically early phase studies, and they don't have any comparative arm in them. And in these studies, the exact tumor location was not available for some patients. And in this keynote 158, the overall response rate was 5.8%, with the PFS at 6 months was 11.4, and at 12 months it's 5.2. And in the other, it was the overall response was 13%. So it's just a marginal overall response rate if you compare with the just high-end drugs, and that too with having MSI high or are they high TMB. So another study, which is again for the refractory advanced biliary cancer tract patients, it's a phase 2 study for the nivolumab. And if you see the patient who received this nivolumab, the response rate means the overall response rate is close to PR is close to 10% of the patients as compared to the patient who, it is not basically comparison, means if the patient does not receive any, means we don't have any options for the patient who have advanced biliary refractory cancer tract. So nivolumab can provide modest, but it's a durable clinical efficacy with a manageable safety profile with a patient who are basically refractory to other first line or second line chemotherapy. And when we don't have any option and patient is still having good performance, you can offer. So to conclude, this is the latest guidelines from the NCCN. If you see, the first line still remains the GEMSIS combination along with the durvalumab, and the second line combination can be chosen whatever the therapies you have. If there is no mutation, you can go with the FOLFOX. And if the patient is having high MSI or TMB, you can give the immunotherapy in those. But otherwise, the prognosis in these patients remains dismal. So to conclude, despite the advances in this cholangiocarcinoma made in the last decade, the prognosis still remains poor for the locally advanced or metastatic. And the mutation discovery of this mutation in IDH1, FGFR2, HER2, BRAF, NTRK, as well as subgroups of the PDL expression and the high MSI or TMB has revealed the fields, but still we are not able to give the good results. And second line and beyond treatment option may give some response in patient with the target mutation. Thanks.
Thank you so much, sir. Any questions for the? So it is difficult to treat, sir, metastatic GB in the refractory cases. There are the few options are there, and in without metastatic also, if it is recurrent GB, then it is also difficult. We all know about the difficulties. So for this, they are the conclusion of the GI with the all the colorectal and then the pancreatobiliary and new therapies, immunotherapies in gastric and esophagus also. Thank you so much, sir.
Thank you, sir.
And now for the organizers for GU cancer session.
Can I have one question? One question. As you have mentioned, there is hardly any benefit of use of durvalumab in the TOPAZ-1 study.
So if you see, the hazard ratio is 0.8 and the difference is hardly 1 month. It's a 12.5 versus 11.3. So
I'm coming to that. So, but if you look at the tail of the curves of the two, so what typically happens is around 25% of the patients will be alive at the end of 2 years if the patient is on durvalumab. So it is something which is probably not what we normally see in practice. If I tell my patient that there is a 1/4 chance, 1 in 4 patient might survive for 2 years, do you think this is a good enough reason to consider durvalumab?
At presently, I don't think. Whatever you have pointed out, maybe once we have seen with the patient with the colorectal cancer, we are given immunotherapy. So we can switch from the 2 weekly to or 3 weekly to, we can switch from to the longer durations. So some of the effects is still maintained. Maybe that can be explained. Possibly I don't have reason.
So typically there will always be few patients who might be sitting on the tail. And that is something which we don't know since we don't have a biomarker.
Yes. But the thing
that is something which of course the time will decide. But then there is some hint that something is happening good for a certain set of patients, just that we don't know which patient.
Yes, I do agree. But at the financial toxicity is very durvalumab is very costly. And I think majority of the patient, if you tell the prognosis and outcomes, they will not be easily convinced for the durvalumab.
But sir, this is a good therapy for the, if there is a chances of there for the response to durvalumab, it will be long lasting for these patients.
Maybe with more of the time, we'll have a better idea. So
because the end curve is that more separating than the chemotherapy alone. Thank you, sir. Thank you so much.
Thank you so much.
Thank you, Dr. Jagdeep. Thank you, Dr. Singh, for excellent session. And Dr. Nikhil, very good point that about the TOPAZ. And we respect and we know that subset of patients will always do good. And when we discuss the science, the economics remains the secondary things. And probably we all want to learn more of science and less of economics. And it's a good point. Thank you so much. So with this, we start the GU cancer session. And to start with the first session, may I request Dr. Nikhil Gadialpati. Dr. Nikhil Gadial Patil is Senior Consultant Medical Oncologist at Yashoda Cancer Institute in Hyderabad. Very active, very dynamic chap. Thank you, Dr. Nikhil, for coming to Jaipur. He's talking on management of metastatic hormone-sensitive prostate cancer.
Thank you so much. Thank you for the kind introduction. And at the outset, let me thank the organizers for this opportunity. I think after COVID, I think this is the first time most of us are meeting in Jaipur, and something I'm sure most of us are quite upbeat about. Today, incidentally being International Men's Day, 19th November, and it's quite prudent on the same day that we are talking about one of the important cancers for so-called mankind, that is a prostate cancer. And my job over here is to discuss about the management of metastatic hormone-sensitive prostate cancer. Now, we do understand prostate cancer is a broad spectrum of disease, and there are times when the patient particularly presents in one particular set, like very early stage, or non-metastatic castrate-resistant, or metastatic hormone-naive, castrate-resistant, metastatic, and so on and so forth. So my job over here is to really discuss exactly the hormone-sensitive metastatic prostate cancer and why it is important to treat this particular set of patients. As we know, there are almost 15% of cancer patients who have metastasis at the time of diagnosis. Now, remember, these are Western data, and I think most of us who are treating the Indian doctors probably would agree that majority of their patients might be in this particular subset. This is something to do with the I would say underwhelming prostate cancer screening, which are still not really penetrated to the extent what is supposed to be in the society. So that is one part of it. And also, if you really know the number of patients who eventually die, there are majority of patients of prostate cancer who also are diagnosed in the hormone sensitive setting. Still majority of the patients will die. We do understand that these patients after some time of initial treatment will eventually land up with the CRPC. So it's a large spectrum of patients what we are looking at. So as I already mentioned, the patients may be diagnosed in various phases, like in a localized versus metastatic, sensitive versus resistant. But my job over here is to really specifically discuss about newly diagnosed metastatic hormone sensitive prostate cancer. And that is where I'll stick to my today's discussion. Before we jump onto the management part of it, let us try and understand the definition of metastatic hormone sensitive prostate cancer. Now, it also has other names like castrate-sensitive prostate cancers or castrate-naive prostate cancer. They're all interchangeably used also. And the typically metastatic prostate cancer, which still responds to ADT. So that is extremely important. This is an important caveat when we talk about a definition. Now, this definition comes from NCCN. And not necessarily always ADT naive. That patient might have received this particular treatment at some point in time, even in the curative part of it. That is in the primary therapy when the patient was non-metastatic, finished his hormones for some time, or for whatever reason only received one unimodality of therapy, and the patient is still eventually become metastatic. But this also can be considered as hormone naive or castrate sensitive patients. Now, when you talk about the treatment decisions, there are multiple factors what one really need to consider, and that includes the disease-specific factors and, more importantly, the patient-specific factors also. And when you talk about the disease-specific factors, we talk about the extent of the disease, the low volume versus high volume, high risk versus low risk, distribution of metastasis, visceral versus non-visceral. What about symptomatic patients versus asymptomatic patients? Are we justified in treating asymptomatic patients? So there are multiple, I would say, factors which are really need to be looked into. In terms of patient-centric factors, one really need to look into the comorbid conditions, as we do understand that these are the diseases which are typically the diseases of the older age, with a lot of comorbid conditions running in the background. That is very characteristic. Coming to the treatment part of it, the androgen deprivation therapy remains the mainstay of treatment for hormone-sensitive prostate cancer, and that is something which we are all aware of right from the year of 1941 when Charles Higgins had initially demonstrated. From that point in time till now, I think we have come a long way in terms of our understanding. Having said that, ADT is typically, I would say, the typical honeymoon period of prostate cancer, where lots of good things happen with the patient in terms of their symptom control, in terms of getting their PSA controlled. Everybody is happy, the doctor is happy, the patients are happy. But eventually, it always, as we know that these patients are bound to become castrate resistant, and almost it's like a rule for the patients. When is something which we don't know. But the longer the patient goes with the first line, that is how the patient eventually going to survive longer. And there are always other modalities which are responsible or which are required to increase the survival of the patients. And there have been various ways that has been tried and tested. And it starts with the chemotherapy, which is a docetaxel-based chemotherapy. Then there are drugs like abiraterone and drugs like receptor blockers like enzalutamide, and newer drugs, which of course I will discuss over here. And I'll also discuss a bit about ADT with radiotherapy in this regard, even in the metastatic setting. Coming briefly about the androgen deprivation therapy, we do know that surgical castration versus medical castration, there has been debate, there has been options. Most of the times it is given to the patient. But cut long story short, it's as simple as that: the patient goes to a surgeon, the patient gets castrated, patient goes to medical oncologist, patient is counseled for both the options. And I'm sure whether you are in Jaipur or maybe Jayanagar somewhere, the story remains same for most of us. Having said that, the surgical castration remains one-time option. It has its cost effectiveness in especially in the rural, or I would say resource constrained settings. So that is quite an important way of treating the patient. Medical, we know about GnRH agonist and antagonist, GnRH agonist in the form of coserelin, buserelin, and so on and so forth. GnRH antagonists, we definitely have data coming up with the degarelix. A quick word about the flare phenomena which can happen with the GnRH agonist, especially when the patients have got a very large prostate where there always a risk of initial urinary obstruction or impending cord compression. These are the patients where one need to be really be careful about. Symptomatic versus asymptomatic, shall we start the treatment immediately or shall we wait, is a question. In a symptomatic patient, all this androgen deprivation therapy has shown to improve excellent palliation, if not the survival. So that is what it is. But in a asymptomatic patient, where the patient hardly has any symptoms yet has a documented disease, there is shown to be a bit of a survival benefit when you use ADT. In addition, it also prolongs the eventual fracture risk, also prolongs the long-term issues related to prostate cancer and metastasis. So this is how science tells us to probably use ADT in all these patients. Whether we talk about early versus late, again, we know that the patient who receive early ADT tend to do well than the patients with the late ADT, especially when talk about the bone-related issues when we talk about prostate cancer. Intermittent versus continuous ADT. Now, this has been a debate for quite a long time, but which has been resolved in the recent times, especially with the data coming from the INT 0162, which does tell us that the patient who received continuous had a better progression and better survival, in fact, OS, as compared to intermittent. The reason why intermittent was tried for, especially in terms of long-term side effects and whether we can mitigate side effects by reducing the doses of ADT, and that was the reason this particular trial also looked into this particular subset. And the long story short over here, seems to be a benefit over here. So when you come to the ADT treatment for metastatic castrate-sensitive patients, ADT alone, which is something which is rarely done these days, especially for some very frail patients who probably may not have too many options left or may have too many comorbid conditions. But in general, almost all the time, the ADT is combined with a partner drug, and that is something which I will discuss in my subsequent slides. What drugs? Degarelix, I already mentioned, GnRH antagonist versus agonist. The benefit seems to be there with the GnRH antagonist, with the faster correction of the testosterone levels and faster castration, less than 96 hours. So that is quite important, and it works more like a surgical castration, where one need not be stressed about the flare reaction which can happen with the GnRH agonist over here. Another new hero on the block is relugolix, which is an oral GnRH antagonist, which when it was compared with the leuprolide, and again you can see the castration rate, sensitivity rate was much higher with the relugolix as compared to testosterone. Again, there is no flare. As we know, this is the oral drug, and this is something which has already been made enough noise in the recent times in terms of its data part of it. Coming to the metastasis, or how to really determine the volume, low volume, high volume, and oligometastatic. Now, there are various definitions which are available, and one of the definitions what typically come from these initial docetaxel studies was more about high volume means more than 4 meds with one or more extraction, with or without visceral metastasis. When you look at the Abiraterone studies, the definitions are slightly different, where they do talk more about high volume as well as high risk, where they talk about the Gleason score of more than 8, we talk about PSA more than 40, in addition to other criteria. So it is important to understand volume is extremely important, because that is how we normally determine therapy. And these are the considerations when you try and determine the treatment, what is the best treatment option for the patient, whether we should go for ADT alone or add drugs like docetaxel, abiraterone, and newer drugs. Of course, what about the triplet, which is again, we talk a lot these days, especially in the various conferences. And as I mentioned, volume remains one of the important key steps to determine which particular treatment we are going to offer to the patient. So these are kind of certain, I would say, consideration which need to be really looked into when you talk about these particular drugs. And here, sorry, 1 second. So here, what you can see over here is there are other, as we have mentioned about the patient comorbidities, but even in the context of Indian setting, that financial toxicity also need to be looked into, comorbid conditions also need to be looked into, compliance of the patient, follow-up of the patients. Each and every factor remains extremely important, and especially when we are treating these old patients, and one really need to look into all these factors. So these are some of the important key studies which have been done in the space of metastatic hormone-sensitive prostate cancer. We know about is a GETAC-15, Charted, Stampede, all to do with the docetaxel. And then there we have Abiraterone arm of Stampede, Latitude, which are again to do with the Abiraterone, Titan with apalutamide, Enzamet with docetaxel with the enzalutamide plus ADT. Archis was without chemotherapy enzalutamide, and Aramis, which is which has tried and tested the darolutamide. We'll quickly run through these studies, and of course, last but not the least, the radiation arm of Stampede, which we'll also look into it. So this is a typically pivotal study of docetaxel. These are, one is a Charted, another was Stampede, slightly different study protocols. And here the patients were randomized to receive in Charted dosi versus ADT alone. And that led to the median OS of more than, I would say, 13 odd months when the patient who received docetaxel. And again, in the Stampede, there was again almost 10 months benefit in terms of survival. So both these studies clearly showed a significant clinical benefit, and also which was statistically significant. When you look into the meta-analysis of all these studies, including GETAC-15, the benefit seems to be consistent across the trials when you use standard of care, which is more of a ADT with docetaxel versus only standard of care, and that led to the approval of these particular drugs, especially in the first line. But whether for all patients, if you look at the high volume versus low volume disease in a Charted, the benefits seem to be quite evident for the high volume disease as compared to the low volume disease. And considering the toxicity which is involved with the docetaxel based therapy, with especially the high volume with the low volume disease, one can refrain use of docetaxel when the patient actually has a low volume, and there are other safer options which might be available. But high volume, this remains one of the important combinations over here. Coming to Abiraterone, the two studies which were done was, one was a Latitude and second was a Stampede. And here again, patients with the high risk, as I mentioned, if you look at the definition, was slightly different over here. And what these both studies have shown, that there has been a consistent benefit of use of Abiraterone to the plus ADT versus placebo with the ADT. Again, it's a clear difference. We look at the hazard ratios, almost 0.6 to 0.63 in both the studies. Again, making it as another standard of care in the hormone sensitive setting in the first line, along with the ADT. When you look at low versus high volume disease over here, again, the benefit seems to be higher with the high volume disease. Again, HR of 0.62 with a significant p-value. But even with the low volume disease, there seems to be a significant hazard, but the p-value is not significant. Having said that, it has shown its benefit also in the low volume disease, which is again clinically meaningful. And that is one of the reasons why Abiraterone may be considered also for low volume disease along with the high volume disease. The new generation androgen receptors have definitely moved up the ladder in the last few years, and these drugs, apalutamide, enzalutamide, something which we use a lot in the castrate-resistant setting. And last but not the least remains darolutamide. Darolutamide has slight benefit because it has slightly low blood-brain barrier penetration, and as we do know with the enzalutamide, there is always a risk of seizure precipitation, and that is something which is much less common with the darolutamide. Studies about these particular drugs, one was the apalutamide. The study was done without docetaxel over here. So apalutamide ADT versus placebo ADT. There has been a benefit in terms of PFS, and there has also been benefit in terms of OS over here. And that also makes apalutamide, of course, which is not available in India, but remains a very important alternative option or alternative in this particular HSPC setting. So this is again a positive study. Arches, this was the study which was done almost like a similar study design. So you look at the abiraterone study, you look at the a previous study of apalutamide, and you also look at this enzalutamide study, that is Arches. Very similar trial designs, ADT, placebo, and enzalutamide over here without or with or without it. Again, this is a positive study. Now, this study looked into the relapse progression-free, radiological progression-free survival in these patients. And here, again, as you can see clearly, the curve starts separating right in the beginning, and there has been a clear benefit over here in terms of overall survival with a descent hazard ratio. Now, coming to some of the triplet regimens which have been tried in the recent times, one of these triplet regimes, Enzamet, had this combination of uses of initial couple of cycles of docetaxel. And here, as you can see over here, there is a benefit of use of enzalutamide with docetaxel. But when we only look into the no docetaxel arm, when you add docetaxel, there seems to be no benefit. It just tells you that the total benefit seems to be coming more from the docetaxel rather than enzalutamide. So this particular trial is negative for the OS part of it. And that is one of the reasons this study, despite having a PFS benefit, has shown that this study has not shown benefit in terms of OS. Coming to the PEACE study, which tried to combine abiraterone, docetaxel, and ADT. And here, as you can see, when the abiraterone was added to the standard of care, there again, look at the hazard ratio over here is 0.5 with a p-value of 0.0001. So this kind of has already become one of the standards of care, and also by various recommendations and guidelines. Of course, when you add more and more drugs, you add more and more toxicity, and that is also evident when you look at the adverse effect profiles of the two arms over here. I won't be covering it because of the short of time. And when you look at the volumes, high versus low, there again has a benefit both in the both the subsets of populations. So this triplet can be considered in this group of patients as another standard of care, especially when you talk about first line HSPC metastatic setting. Again, OS for high volume, there is always a trend towards OS benefit, but not with the low volume for now. And a quick word about the darolutamide, which again combined on a similar lines, ADT docetaxel with or without darolutamide, which is again I would say cousin of all these enzalutamide and other drugs. And here again, there seems to be a clear benefit when you add third drug in terms of the survival benefit on almost all fronts, including the late endpoints like fractures and subsequently to become castrate resistant and so on and so forth. When you look at all these hazards, what we have seen through all these studies, they are more or less similar. We talk about doublet, we talk about triplet, but there seems to be a benefit consistently. Having said that, we always are aware of cross-trial comparisons, and that is something which I would like you to bring to your notice for sure. A quick word about radiotherapy in a low volume, low metastatic burden patients, and what is the role of using prostate RT, and there seems to be benefit over here in terms of the OS. And these are the very select group of patients where one may consider adding a prostate RT in addition to the ongoing therapy. But this is one of the definite important caveats what one should remember, especially when you look at extremely low volume oligometastatic prostate cancer patients. So this is the summary. Now we know that there are a lot of options which are available. ADT remains the key treatment for almost all the patients. We have positive trials with the docetaxel. We have positive trials with the abiraterone. Then we have positive trials with enzalutamide, apalutamide, darolutamide in a triplet. So there are a lot of information and a lot of trials which are available. It is important to really understand what are our patients' needs, what are the comorbid conditions, and accordingly one can think about it. So treatment strategy will depend upon the extent, volume, high volume versus low volume. Some studies are taken into high risk versus low risk. One need to really be very much aware of those particular factors, comorbidities. the duration of response, cost and availability, there are certain drugs which are still not available with us. And as I mentioned, for high volume disease, a triplet remains one of the options. We only have started using only for a few patients who are extremely young and fit patients. Otherwise, we are happy with the doublets for now. Docetaxel remains one of the drugs for high volume disease. For low volume, abiraterone as well as enzalutamide remains options. High risk, again, chemotherapy it remains an extremely good option over here. High symptoms, docetaxel remains an option. Something which I have not covered much is the bone health, but I am sure most of us probably are very much into treating bone health, and that is something which has becomes a quite integral part of use of the bisphosphonates or rank ligand inhibitors. Which protocol, how many injections, 6 monthly versus 3 monthly, remains a discussion for some other day. This is the NCCN guidelines, and here you can see ADT remains the mainstay for treatment. Options include abiraterone, options include docetaxel, options include enzalutamide, and along with that, triplet regime also has got a category 1 recommendation in the recent NCCN upgrade. So conclusions: treatment intensification with docetaxel or AR-directed therapy is a new standard for metastatic HSPC. ADT alone single treatment is no longer a standard of care, something which all of us are aware of. And treatment intensification is preferred regardless of how fast or how quickly the PSA falls. Quality of life, again, it is quite an important part of it. One should really look into when you talk about triplets, the quality of life may be at jeopardy, and one really need to look into that. So with this, I stop here and thank you for the patient listening.
So any questions or comments from anyone? Nikhil, can you highlight the intermittent ADT versus continuous ADT? Like these patients are going to survive for 4, 5, 7 years. So,
correct. So I think that is quite an important question, and it's like, there are basically two sides of the stories, and one should be aware of both sides of the story. The very reason why intermittent was tried came from the fact that the patients are almost like they are long-term survivors, and long-term survivors, when you treat this patient with the ADT for extremely long time, come with a lot of baggage, and that was one of the premise that particular study, of course, that study, this was not the only primary endpoint, but if you look at the INT 0162, which they actually looked into the patients who were more than PSA more than 5 and treated with continuous versus intermittent, and there were 2 endpoints when the patient again achieves the baseline or crosses more than 20 where they can restart. The patients who did not receive, who received intermittent versus continuous, there has been almost a survival benefit of 2 years. And that kind of led to understanding that patients who probably are on intermittent may not do as well as compared to the patient with the continuous one. And there is always a chance of getting more and more resistance part of it. But the other side is definitely the tremendous adverse effects which some patients do exhibit, like hot flashes and lipid hypercholesterol.
In fact, 15 to 20% patients are reported to have cardiac side effects.
Cardiac side effects, lipid profile. So there are issues. So one has to know both sides of the stories. We try to do as much as possible continuous for now.
Thank you. Thank you so much.
So there is only this one study, which is, of course, which I had showed in one of the slides, where in the oligometastatic setting, there has been a survival benefit if you give the radiation to the primary, but that is only one study. But I think that is something which
consider it in the lymph node, regional lymph node positive.
Correct. So only that. So these are basically very low volume metastatic. That's what exactly what.
In fact, that is also very important, very relevant, that in low volume disease, even with metastatic disease,
one should
give radiation.
And sometimes we tend to miss out because we are already mentioned it's a metastatic, but this is one of the studies which has mentioned about benefit. Yeah.
Thank you. Thank you so much, Dr. Nikhil. And next session in on the management of non-metastatic CRPC. So, which will be delivered by Dr. Asim Samar. Asim is very good friend of ours, very vibrant academician in Bhagwan Mahavir Cancer Hospital. He is currently the in charge for DNB training program in Mahavir Cancer Hospital. And he'll be speaking on management of non-metastatic CRPC. Over to you, Asim.
Thank you, sir. And thank you, organizers and Dr. Sandeep Jasuja who has called me and given the opportunity for this. We'll start, and briefly I will touch upon the topics, and most of the topics and slides are covered by Dr. Nikhil, who is my senior also in Tata. My talk is very well constructed with the subgroup of the patient who has non-metastatic CRPC. So it is like prostate cancer is second most, just brief introduction, second most common malignancy in the main worldwide, and various part of the stages patient we diagnose, like early stage, sometimes they are in the advanced stage. But in India, almost 60 to 70% of the patient we diagnose at the metastatic stage, and there is a barrier of starting our treatment in non-metastatic CRPC. So it is most of the Western concept where they found the patient in the non-metastatic CRPC. But in our setting, they are less common. But as the primary treatment is available in nationwide, we are finding more and more cases. After primary treatment, localized or locally advanced disease may progress to biochemical recurrence, sometimes termed as biochemical failure, and it is usually within 5 years. So this Dr. Nikhil has talked about great surgeon Charles Huggins, who has just introduced ADT in the treatment paradigm of the prostate cancer. So many of his patients were having bone mets and terrible pain of the bone mets. So he just noticed that if we give estrogen or androgen injections to them, the patient immediately get relief in the bone pains. So his observation was, if we give the androgen or estrogen injection to the patient, immediately the serum phosphatase level goes down, and that was the first discovery, and that led to the ADT into treatment paradigm of the prostate cancer. And what is the castration resistance? So suppose we have started here. So I will, which is the pointer? Anyways, okay. Usually it is combined. So suppose we have started treatment here where the testosterone level was high, and we have given ADT. So subsequently the testosterone goes down, and at some point of time it is below the 50 nanogram per deciliter per ml, and that's by definition it is a castration level. And once the testosterone level goes down, PSA will also fall, and it achieves the nadir. But after some period of time, it again started increasing. That time we know it is a castration resistance. So earlier we used to see we used to understand like CRPC is not hormone, it is hormone refractory state. But now we know by the discovery and genetics, like it is frequently the hormone ultra sensitive disease. The tumor itself become ultra sensitive to the lower concentration of the testosterone, and it start growing. Why it happens is, it is a selective pressure put upon the cancer cells by the continuous use of androgen deprivation therapy. So it happens, adaptation of the cancer cell, it happens in the terms of, this is AR deregulation, androgen receptor deregulation, and commonly this intracrine endocrine synthesis. Tumor cell itself produce testosterone, and it goes and have the intracrine effect of the tumor cell. So tumor again start growing. This is splicing variants of the androgen receptor. Sometimes it happens. This is the cofactor perturbation, mutation of gain of function, and this is alteration of the modification of various subunits of the androgen receptor. This is the adaptation theory, and this restored as the androgen receptor activity. Again, PSA start formation and tumor start growing. So this side we will cover later because we have short of time. This is the chronology of the disease. So suppose we started treatment here. There was a localized disease, but patient has biochemical relapse. We have treated this patient in the localized stage with the surgery or radiation, and again patient after some point of time patient started increasing the PSA. There is a biochemical failure. We start treatment here, this ADT, patient again achieve the nadir, and after some point of time, some period of time, patient started progression, PSA progression, biochemical failure. But we especially know that sometime, for the most of the time, patient may be non-metastatic. So we are considering this block of the patient non-metastatic CRPC. And this all we know, and the later talk will cover this metastatic CRPC. So why we want to treat this patient in the non-metastatic CRPC state is because once patient is progression of the non-metastatic CRPC to metastatic disease is likely, and approximately 1/3 of the patient will develop mets, bone mets within 2 years of time. So we want to prolong this time period. As long as patient is non-metastatic stage, patient will be comfortable, they will require less care, they will have less bone pain, all that. And the survival will increase, and later on we will see in the slides, like all-cause mortality in the non-metastatic stage only 16%. But if the patient get mets, it is 56%. So ultimately, if we prolong the duration of non-metastatic CRPC state, we will prolong the overall survival. So the patient, what are the factors which produce this metastatic CRPC? So we can predict, like, if patient has a high PSA concentration at diagnosis and shorter PSA doubling time, high glycemic score at baseline, and shorter interval from ADT initiation to diagnosis of the CRPC, that kind of the patient of non-metastatic CRPC will convert faster into the CRPC. And it is generally higher limit is 2 nanogram per ml. So it is non-metastatic CRPC. Non-metastatic by the conventional imaging methods. Now the bifurcation according to NCCN is, if PSA doubling time is less than 10 months, that means it is an aggressive disease, and we need to consider this kind of the drug, apalutamide plus ADT, enzalutamide or darolutamide. If PSA doubling time is more than 10 months, the disease space is low, and you can continue with the ADT. So the first publication happened in this Lancet Oncology in 2019, and subsequently in 2020 September, this published in the New England Journal of Medicine, RMS trial, non-metastatic castration-resistant prostate cancer and survival with the darolutamide. So what was the treatment schema? RMS trial design was global, randomized, double-blinded, placebo-controlled trial, phase 3 trial, and the purpose of trial was investigating the safety and efficacy of the darolutamide in men with the non-metastatic CRPC. So the primary requirement was the non-metastatic CRPC patient, and PSA doubling time should be less than 10 months. The patient were randomized into 2:1 fashion. Experimental arm had ADT plus darolutamide, 600 mg BD, and ADT plus placebo in the control arm. And the primary analysis, the endpoint was metastasis-free survival, and final analysis was OS, overall survival. Primary endpoint was MFS, metastasis-free survival. Secondary endpoints were 4: overall survival, time to pain progression. It is very important for clinician perspective. Time to first cytotoxic chemotherapy use, and time to first symptomatic skeletal event, and safety and side effect of the darolutamide. Some exploratory analysis was also done. So we'll see if the patient had a high risk disease like PSA doubling time is less than 6 months, then darolutamide adding to the ADT arm was fare better, and the median this PFS was metastasis free survival was 34.3 months as compared to the 17.2 months in the ADT alone arm. So it was significantly better. HR ratio was 0.41. That means 59% of the patient had benefit with the adding darolutamide to the ADT arm. If PSA doubling time was 6 to 10 months, they have stratified according to the previous plan. So it has, you can see it is only ADT arm had the 30.7 month, and here it was a 40.5 month. Or maybe it has not reached, so it was significantly better. And HR ratio was 0.38, which is very significant. 62% of the patient had reduction in the risk of metastasis or death. Secondary endpoint, we know we have assigned like time to pain progression, time to first cytotoxic chemotherapy, and time to first symptomatic skeleton event. All three parameters darolutamide proved to be better. This is better, and this has not reached actually. So time to pain progression was in the darolutamide arm, it was 40.3 months versus the darolutamide arm, it was alone arm, placebo arm, it was 25.4 months. So clinically, this is very important. And this is the PSA response. We follow up our patient with the PSA level measurement. So this was also better in the arm of darolutamide. Almost 51% patient had reduction of 90% of the PSA concentration, and 32% patient had PSA reduction in 50 to 90%. Whereas in the placebo arm, it was very minimal, almost 8%. And median change with the darolutamide was 87.4% in the PSA concentration. What is darolutamide? Darolutamide is a newer third generation androgen receptor inhibitor. And what is the mechanism? So darolutamide, we know like testosterone comes here, and it goes and converted by the 5-alpha reductase to DST. DST along with the androgen receptor, it's translocated into the nucleus and attached to the DNA, and then it causes the growth and survival of the cancer cell and increase the PSA level. So darolutamide block this attachment of the DST to androgen receptor and translocation of the this complex to the nucleus, and ultimately block the progression of the cell. It is the commercially used available darolutamide, and it is now available in India also. This is the comparison of the all four androgen receptor antagonists. So you can see we will consider our darolutamide. It is a full antagonist, and it blocks the nuclear translocation. The mutation of the AR receptor has not been described for decreasing action of darolutamide, and it generally no progression of the testosterone level. It will not increase with the darolutamide, and blood-brain barrier is very well, means it does not cross the blood-brain barrier. So there is very minimal side effect of CNS side effect. This is the median. These all three trial compared, and one slide. You can see like median time to PSA progression was 37 month here, and 33.2 month in the Aramis trial, which was significant, and median PFS was almost similar in 3 arm. So what was this is the side effect profile. You can see in the apalutamide, enzalutamide, the side effects are very troubling, but in the darolutamide arm, the darolutamide trial, it was very less. And in this network analysis where the 3 trials were compared, and other studies also with the similar endpoints, they have clearly mentioned this AE AEs were very less with the dolutamide, and efficacy wise eflatomide and enzalutamide was little bit superior. But in further analysis, they have shown dolutamide may not be only provide best OS, but there's a favorable side effect profile and in the non-metastatic CRPC patients. And now this is the last slide, which shown like if you have a PSA doubling time more than 10 months, you can observe. But if less than 10 months, dolutamide is a category 1 indication. Thank you very much.